everybody here. So this afternoon, we're going to hear some wonderful case debates. And this is the second series, and we have two distinguished teams here that I think have been hard at work. And we're going to have a discussion today about actually a very nice clinical conundrum that we all face, which is portal vein thrombosis and cirrhosis. And there are multiple ways to approach this. So we're going to hear about the cases for anticoagulating these individuals as well as observation. And so welcome to our two distinguished teams here that look very non-competitive. And so we're going to start, and we can start in any particular order. Why don't we start closest right here? Welcome. Why don't you introduce yourself to the audience? Tell us which of the positions that you are going to advocate for and why the other team is wrong.
Yeah. My name is Salih Tokmak. I'm working as an associate professor of GI in Düzce University in Turkey. Today we're going to talk about anticoagulating the patients. First of all, I want to thank the organizing committee for giving us the chance to participate in this debate, especially in the presence of Dr. Jackie O'Leary, who wrote the guidelines, AJA guidelines, practice update on 2019. It's an honor to be here. And then I want to thank the organizing committee again for giving us the task to advocate for the anticoagulation, because as you will see, this is not a debate. So you have to anticoagulate the patients, and we will show you the data. So I want to thank the organizing committee again for that. So, yeah, we have nothing to disclose. First of all, I'm going to talk just a little bit about the prevalence and incidence and classification. I'm going to talk a lot more about the pathogenesis and why should you give anticoagulant therapy. And then I'm going to hand over the microphone to Serjan to do the heavy lifting about the efficacy, management, and safety, because after all, he's younger than me and he's more handsome than me, so he should do the heavy lifting, I think. Yeah. So, as you can see, portal vein thrombosis is an interesting entity. As the disease progresses, as the patient gets old, the incidence keep getting increased. But almost half of the patients are asymptomatic. So that's unlike any other thrombotic events. And as you can see, almost 3/4 of the patients' thrombosis are regresses or gets a resolution. So that's interesting. So I want you to keep that in mind. And as the disease progresses, as you can see from the child A to B, the incidence of portal vein thrombosis increases almost twofold, and the prevalence of PVT in pre-transplant patients is almost up to 40%. So that's an important problem we have. How do we classify? We classify based on time, as recent and chronic for the 6-month threshold. We classify as the location of the thrombosis, as the length of the clot, and as the percent of the lumen occluded. Why do we classify? To help us get a judgment about what we will do. But there is something wrong here. So what we do know is that in cirrhotic patients, a lot of changes happen, both in anti-hemostatic pathways and both in pro-hemostatic pathways. But a delicate, mark my word, a delicate rebalance occurs, so the patients do not get prone to prothrombotic or antithrombotic states. And we do know that this delicate rebalance may easily get unbalanced, and so based on some hepatic conditions and also some systemic conditions, it may be easily get unbalanced. And there may be an injury to the portal vein endothelium, and then there comes your virtual triad, and so a thrombus occurs. We used to think that. But as you can see, as the guideline points out, there are variable clinical presentations and significance. How come? Why is that like that? Because it seems that we were wrong. The problem is, despite being a vein, the portal vein's intimal thickness increases. Why? Because of the portal hypertension. That's a reactive situation. And in patients with cirrhosis and portal hypertension, as you can see, the intima media gets hypertrophied and gets fibrotic. And when this lumen gets occluded, it's so easy to a thrombosis to occur. Why? Because the velocity of the portal blood vein flow decreases. So how come? Is there any base for that? Yes. It's a very known fact with the Poiseuille's law. As you can see, if the lumen gets obstructed for 50%, then you have almost 94% reduction in your blood flow. So if your blood flow decreases, so it's only natural to have a thrombosis. So is there any examples for that? Yes, there is. In patients with saphenous vein graft failure after coronary artery bypass surgery, in the late period, the main reason for the graft failure is generalized neo-intimal hyperplasia. So you think that only arteries may have intimal hyperplasia, but no. As you can see, with the increased pressure comes the intimal hyperplasia of even the veins. So is there any data that supports that? Yes, there is. So as you can see, the only independent risk factors for PVT is the increased portal hypertension, which you can see with the decreased thrombocytes and the increased variceal bleeding. And also, as you can see, the only factor is decreased portal blood vein velocity. So you can think that it's because of endothelial injury and the Virchow's triad. As you can see, none of the acquired or inherited alterations in coagulation does not predict the PVT. So why should you start the anticoagulant therapy? Especially this narrowing phenomenon is important because from almost 30 years we know that if you have more than 10% of luminal narrowing, then you have more than 33% of the blood flow related parenchymal extinction, atrophy. So there are, as the guideline states, microthrombi occurs, and those microthrombi causes inflow obstruction and your parenchyma, liver parenchyma gets atrophied. So this is directly related for the overall survival. But as the guideline states, there's a need for the randomized controlled trials for that. Do we have any randomized controlled trials? Yes, we have one, albeit with small number of patients, 35 patients in each group, as they show that your overall survival increases with the anticoagulation therapy without any major bleeding events. Another important point that we should use anticoagulation in these patients is the setting of a liver transplant. This is a well-known entity in patients with portal vein thrombosis before transplantation has lower rates of survival, both in 30 days mortality and at the 1-year mortality rates. Another very speculative, and I know I should be careful about that, but the use of beta blockers also causes portal vein thrombosis. So there's a dilemma. I told you that portal hypertension causes portal vein thrombosis, but we use beta blockers to reduce portal hypertension, but the beta blockers which we use to reduce the portal hypertension cause portal thrombosis itself. How? It's because of the decreased portal blood vein flow velocity. So as you can see in this large systemic review and meta-analysis, which I know is very heterogeneous, but shows that the increased risk with beta blockers about portal vein thrombosis. If you look at the subgroups, even in the cohort studies, even in the case control studies, even in the European-based studies, and even in the high-quality studies, which we can show that Newcastle-Ottawa scale is equals to or larger than 7, which can be only as much as 9, even in the very well-designed studies shows that a clear risk with beta blocker use and portal vein thrombosis. Beta blockers not only causes a portal vein thrombus to occur, but they also causes progression of an existing portal vein thrombosis. So only thing you can do is to give the patient an anticoagulant. So thank you very much.
Thanks, Salih, for excellent introduction. And I'm trying to complete our section with the management efficacy and safety. First of all, I want to also thank the organization committee for giving us this opportunity. I will start my section with talking about AJ clinical practice update, which we published in February 2025. When we detect the portal vein thrombosis in a patient, First, we should check if these patients have an urgency condition or not, intestinal ischemia or intestinal infarction. And if we exclude this condition, we should make an esophageal varices screening. Because for some conditions, especially for esophageal varices containing high-risk stigmata, we should apply for endoscopic variceal ligation or non-selective beta blocker treatment. And after that, we should take a decision that, especially for these patients, if they need an anticoagulation therapy or not. Especially in patients with cirrhosis, decisions for treatment of an individual patient should be based on expected benefits and minimization of clot extension and risk that could potentially lead to progression of portal hypertension or hinder liver transplantation. Especially patients with liver cirrhosis, if a patient has recent thrombosis within the 6 months, it contains in small intrahepatic branch ducts or minimally onclusive, we can observe these patients with serial imaging every 3 months. And therapy is, therapy may be reasonable. But especially in these patients group, if they experience a clot progression or if they become symptomatic, also we should evaluate these patients for anticoagulant therapy. And the second part, if patients have occlusive or partially occlusive portal vein thrombosis of the main portal vein or mesenteric vein, anticoagulation therapy should be initiated because especially these patients group has a great potential for liver transplantation and also especially in this patient group, recanalization chance is very high. And the other third group, if they have chronic complete occlusion or cavernous transformation, it is not clearly established that they give benefit from anticoagulation therapy. But in a small proportion of this patient group, if they have a small chance for liver transplantation, especially in the complete occlusion group, maybe anticoagulant therapy may be beneficial for this group because preserving their vascular structures. And in this patient group, recanalization rate is very low, but we can consider this patient group case by case. And I want to talk about a systematic review and meta-analysis which published in 2017, and they both evaluated they both collected data from studies about progression of portal vein thrombosis and variceal bleeding risk for treated and untreated groups. And especially they investigated the time of anticoagulation. First, recanalization can improve portal flow and reduce portal hypertension, potentially reducing the risk of future disease progression and decompensation. And second, in patients awaiting transplantation, recanalization preserves, as I said before, anatomic anastomosis and also reduces surgical technical challenges. And the result of this meta-analysis, anticoagulation increased the recanalization rate with a significant odds ratio. And the other condition, we will initiate anticoagulation therapy to patients at what should we think about anticoagulation and bleeding conditions in these patients groups. Especially the patients with cirrhosis and portal vein thrombosis require variceal screening given the established association between portal vein thrombosis, variceal bleeding, and portal hypertension progression. Although endoscopic risk assessment and prophylaxis are important, this is must balanced with delays in anticoagulation because anticoagulation timing is also important for recanalization or complications. Because as we mentioned before, on-time anticoagulation treatment is strongly associated with better recanalization outcomes. Another meta-analysis published in 2023 in Journal of Hepatology, they investigated the efficacy of anticoagulant therapy in portal vein thrombosis patients, and they especially focused the survival functions and bleeding risks under anticoagulant therapy for portal vein thrombosis patients. And this study, they examined 5 studies and nearly 500 patients. They divided groups, anticoagulant group and no treatment group, and they found that anticoagulation appears to reduce all-cause mortality in patients with cirrhosis and portal vein thrombosis. Also, the This is very important. The beneficial effect of anticoagulation on survival is independent of thrombosis, independent of thrombosis severity and recanalization. And as a result, anticoagulants increases the rate of portal vein recanalizations. On the other hand, when we evaluate the bleeding risk, bleeding rates are very similar between two groups. They are not a significant p-value between two groups, and the numbers are very similar. Only rate of non-portal hypertension related bleedings is a little bit higher in non-treatment group, but we think that this is not especially about the directly about the drugs, as we can see these conditions in other indications of these kind of drugs. And because of this, we think that it is not specifically interested about portal vein thrombosis patient group. And the other study about the bleeding risk, they focused especially the safety of variceal bleeding ligation for portal vein thrombosis patients treated with anticoagulant therapy. And they demonstrated that post-ligation bleeding rates were very similar and comparable with the results of non-treatment groups undergoing variceal bleeding. And they emphasized that especially anticoagulation for portal vein thrombosis may reduce portal hypertension, related bleeding by lowering portal pressure via recanalization. And we just checked the current guidelines. They are not uniform in their recommendations on timing of anticoagulation initiation, but especially AASL recommended deferral until variceal prophylaxis is in place. AASLD recommended initiation, if possible, as soon as possible. And Baveno 7 portal hypertension consensus guideline recommends variceal ligation in patients undergoing anticoagulation with warfarin. And overall such data suggests that endoscopic variceal ligation can be performed safely without stopping anticoagulation therapy. Only it is necessary to discontinue these drugs for their pharmacological half-life. And as we mentioned before, when we check out this big meta-analysis, which we mentioned before, they investigated both complete recanalization of portal vein thrombosis, progression of portal vein thrombosis, and the variceal bleeding. And as you see, anticoagulation arm provides better results even at risk of variceal bleeding. And some pioneering studies have been published about this issue. They tried to investigate preemptive use of these kind of drugs. Especially, there is a study published in 2012 in gastroenterology, and they investigated the preemptive use of low molecular weight heparin. And another study both investigated the therapeutic and the prophylactic arm, and they emphasized that especially prophylactic anticoagulant using in patients significantly reduces rates of portal vein thrombosis development, and they have favorable outcomes in both morbidity, mortality, and the severity of the disease. And how can they do this? The estimated and demonstrated mechanisms are especially they decrease portal venous hypertension, they decrease enterocyte damage, and they also decrease bacterial translocation, but they are improving intestinal microcirculation, and also they use the direct effect of enoxaparin's anti-inflammatory effect. And as you see, which I mentioned before the study, enoxaparin, the prophylactic use of enoxaparin provides good results, both probability of portal vein thrombosis, probability of decompensation, also probability of survival. And as you see in this flow chart, almost all roads go to anticoagulation treatment. And what time should we receive these drugs? At least how long should we receive these drugs? At least 3 to 6 months. But our primary outcomes, primary goals are until recanalization or lead the patient to the liver transplantation. And the mainly used drugs in this condition As we know very well, traditional anticoagulants like warfarin and low molecular weight heparin, they are generally safe drugs, but they have some disadvantages like monitoring, especially warfarin, by INR monitoring, or administering the low molecular weight heparin with, by subcutaneous way. But especially new oral anticoagulants provides similar or better outcomes for these conditions. And if we look at these drugs, especially apixaban seems better because it has data, especially in child B7, child B patient group, and we can use for suitable cases. Our presentation has ended. Thank you for your patience.
That was excellent. Thank you so much. And I think we're going to be able to move on now to hear from our next group. Certainly going to be, I'm sure, an interesting debate. Please go ahead and introduce yourself, but we're excited to hear the con side.
Yes, please. My name is Nilkay. I'm from King's College Hospital, and it's a great pleasure to be here today. Thank you for the organizers and you all for your time and interest. And of course, great thanks to your opposite side for their comprehensive explanation, even taking our time as well, but relies on little or even no evidence. Dear colleagues, we live in evidence-based era, so let's check the data on the simple evidence-based pyramids. So do we have any meta-analysis regarding the benefit of anticoagulation? No, zero. Do we have any randomized controlled trials that showed the transplant-free survival under anticoagulation treatment? Only one, which was unsuccessful. Do we have any case control studies? We have a few, but showed only recanalization, no benefit for the overall survival, transplant-free survival, or quality of life. Do we have case series? A lot, but the benefit is so low. So it's simple for over 2,000 years. Please, first, do not harm. Another interesting thing, I think this is a breakthrough of today's discussion. We should check the patient's variance. So we have a couple of patients, let's say, acutely presented with ascites and portal vein thrombosis in cirrhosis setting, or patients in the waiting list for the transplantation. Of course, there's no doubt. We should treat them, and we should keep the transplant waiting list patients' portal vein open. Also, there are a couple of patients in here that the context of BCLCC cirrhosis of portal vein involvement. Of course, there is no discussion. We don't treat them. But please keep in mind that the majority of patients are here under the bell curve. So we are focusing here, but we are trying to generalize all recommendations for the majority of cases relies under the curve. This is not true. So if we look at the epidemiological data carefully, that summarize the entire story. So what are the risk factors for the PVT? On the left-hand side, you can see the risk factors are ascites, variceal bleeding, and advanced stage disease like child P, B, and C. So this is not a problem in general population. It's only 1% in general population. On the other hand, this is a big problem in cirrhosis setting. Every 1 in 7 cirrhotic patients had PVC. This is a huge number. And if we carefully dig more, only 10% of the patients who has compensated cirrhosis shows PVT. On the other hand, this number is nearly 1/3 in the BCLC B and C cirrhotic patients. This further increase in transplant waiting list clinic, and I don't even mention in the HCC. So our colleagues also showed the data. This is, I mean, more than 1/3, nearly 2/3 of them incidentally detected PVT, and at least 1/3 spontaneously resolved during the natural history. This is so important. And another problem, there is no clinical robust data that shows role of the thrombosis play in disease progression. These are all hypotheses, but there is no direct proof that show this impact on the progression. So what we have in literature is recanalization, recanalization, recanalization, but we miss some most important point, which is transplant-free survival, which is overall survival, which is quality of life. And I should kindly remind you all, we are hepatologists, we are not plumbers. We don't mind some fancy good flow in the portal vein, but we do care the transplant-free survival. As a clinician, we should focus on this place. And my colleague will continue from now on. Thank you.
I'm Dr. Zülal İstemihan, Ömer Halis Demir University Training and Research Hospital. Firstly, I want to thank the organizing committee for the invitation. In this part of our presentation, we would like to give some examples from the literature. This study from China included 77 patients with portal vein thrombosis and cirrhosis. With anticoagulation therapy, portal vein recanalization rate was more, and portal vein thrombosis progression was less. But at the end of the study, there was not significant difference in the 2-year survival rate. So the real benefit of anticoagulation is controversial. This meta-analysis from Italy, portal vein recanalization rate with anticoagulation therapy was nearly 70% of the patients, and just nearly half of them was complete recanalization. In non-anticoagulation group, portal vein recanalization rate was approximately 40%, but just 33% of them was complete recanalization. But we don't have any data about clinical impact on survival of these results. So this study shows that anticoagulation does not guarantee, but may only increase chance of complete portal vein recanalization. This is another prospective registry about transplant-free survival in portal vein thrombosis and cirrhosis patients with anticoagulation therapy. Anticoagulation treatment didn't improve overall transplant-free survival, and it's also investigated both child A and advanced cirrhosis separately, and there was not difference. We have an important risk of complication, it's bleeding risk. This group of patients actually are at high risk of bleeding with or without anticoagulation treatment. So we need a bleeding risk stratification before generalized anticoagulation treatment in this group of patients, like cardiologists using Hasbulat score. Another problematic issue is the treatment of child B and C cirrhosis. As it is known, PVT is prevalent in this group, but majority of the studies exclude them. So we don't have reliable data for safety, or we don't have reliable data for outcomes of anticoagulation treatment in PVT and cirrhotic patients. In conclusion, anticoagulation carries significant risk without proven benefits, and we can see spontaneous recanalization, and it's not a low rate actually, nearly 30% of the patients. Clinical decisions must rely on robust evidence rather than assumptions. PVT should not automatically be treated as harmful without strong data. We cannot treat all patients as trial candidates. Real-world settings lack the strict safety protocols of trial environments. Randomized controlled trials are essential to guide. And until stronger evidence emerges, individualized case-by-case decisions remain crucial. Thank you.
Thank you both groups for your passionate advocacy. Do we have any questions from the audience?
Go ahead.
Go ahead.
I want to challenge the Salih. Since he declared that intimal hyperplasia is causing the portal hypertension and thrombosis in these patients. So how can we treat intimal hyperplasia by anticoagulation? So what's the logic you are supporting anticoagulation in these patients?
Excellent question, thank you. So we can treat the intimal fibrosis, that's irreversible. But the decreased blood flow velocity caused by that intimal hyperplasia, intimal fibrosis, can be treated with anticoagulants. So I can increase the blood flow velocity by thickening the blood itself. So in fact, thank you again for this question, because I have also two arguments to be made, but may I or after that? About that. So I'm definitely agreeing with you. We're not plumbers, so we don't have to recanalize the thrombi in the portal vein. But what we have to do is to protect the liver parenchyma. So if you give the anticoagulation, you preserve what you'll have left as an intact liver hepatocytes. So our only aim shouldn't be to recanalize, but also we have to decrease the portal hypertension by decreasing the blood flow velocity, and we have to keep what we have in hand with the liver parenchyma.
May I contribute?
Yes.
Thank you very much. So we do respect your theory and subclinical data you presented, but you are not allowed to implement this subclinical data directly to bedside before RCTs.
Yeah,
Rules are so simple and universal and for everyone without any exception. For this, I mean, to build up this hypothesis, you need to do your RCT and show clear-cut benefit effect of anticoagulation rather than arguing for the possible benefit.
That's right. We don't have solid data. We don't have hard evidence. But not having a hard evidence right now doesn't mean it won't work. So when I asked Dr. Sao Lupe in 2017 in UEG week, why wouldn't we give carvedilol in patients with portal hypertension instead of propranolol? So it would decrease the risk of portal bleeding, portal vein bleeding risks. Very still bleeding risk in patients with ascites. So there were some studies about that. But she told me that we don't have hard evidence. But 2 years ago, they published a guideline with benefits of carvedilol. So I mean, we shouldn't give everyone that. But based on patient discussion, I may even think giving anticoagulant therapy to patients who don't have portal vein thrombosis prophylactically. So because it fits. You know, it's within the physiologic pathway, so it fits. So,
Thank you. You've made your point. Yeah. Sumit, did you have a question? Dr. Asrani.
Shall I add one more point?
We'll come back.
So for the pro team again, you showed the slides with beta blockers, and it made me really scared of beta blockers now. So instead of adding medicine, should I just take away the beta blocker? And that
no, you should give the beta blocker and you should anticoagulate the patient, I believe. That will be my daily practice from now on.
And go ahead.
Since anticoagulation is almost standard of care, I want to challenge pro group much more. Propranolol has alpha blocker effect. Carvedilol has alpha blocker effect. So it decreases the resistance, and that's how it acts. Yeah. So it's good for the anticoagulation also. But you said we should be scared of beta blockers as
non-selective beta blockers. Yeah. So they decrease the portal hypertension, yes, but they also decrease the blood flow velocity. So the main risk is the velocity.
The sludge, the portal vein flow just slows down, and then you can get in a narrow diameter, you'll get thrombosis. And the evidence he showed is actually quite compelling.
And one thing may I add, so the thrombus in the portal vein is not like your typical thrombus. It doesn't have any blood cells in it, so it doesn't have thrombocytes, it doesn't have erythrocytes. It's almost complete of fibrin. So that's why the reason it spontaneously goes away, but it reoccurs.
because your blood flow velocity is decreased. Yeah.
So we could, one more, and then we have to vote because we're behind. So you get the final word.
If we decided to start direct acting anticoagulation therapy, which drugs would you prefer?
Apixaban, one and only, I can say, so far, for the ones that I read, yeah.
You mentioned it, and in your clinical practice also?
With a standard dose, 10 milligrams BID for the loading and 5 milligrams BID for the
in childhood cirrhosis, A
and B, yeah, A and B.
And
I'm even think given to child cirrhosis C, because most of those patients are not transplant eligible, and I have to preserve what we have in the liver. Yeah.
Great. So I think both teams did an excellent job. Thank you so much. But now we're going to vote. So so first we'll vote pro anticoagulation, and everybody has to vote, and then second is con. So we're not going to vote. So pro anticoagulation. That's a lot of hands. Great, and now con anticoagulation. I think it was fairly split, so good job on both parts, excellent job, but I think pros have it by a little bit.
Başlatacak mısın? Başlatayım. Now it's time for portal hypertension session. The first speaker, Dr. O'Leary. Please, Dr. O'Leary.
So it's tough to get back to a didactic lecture after that much fun, but hopefully I'll make this somewhat entertaining. So portal hypertension is certainly a hot topic here and at AASLD. I did not give this debrief, but certainly attended many of the talks, and I thank Brett Fortune for allowing me to utilize his slides. We're going to, like the other ones, go over the different abstracts in categories, but there were more than 200 abstracts presented in the area of portal hypertension. The first being non-invasive diagnostics for portal hypertension and outcomes. The portal decompensation score, a validated predictive model of portal hypertension related liver decompensation events in cirrhosis. This was a large retrospective cohort of compensated cirrhosis patients from Australia, and the goal was to use a score to predict the first decompensating event. They trained on almost 1,000 patients and validated on 2 smaller cohorts. The portal decompensation score incorporated simple values of total bilirubin, ALT, alkaline phosphatase, albumin, and platelets. And you can see that it did an excellent job of predicting those at highest risk for decompensation in the training as well as the validation cohort with an area under the curve of 0.81. Scores like this are going to be needed as MASL drugs go into clinical trials in cirrhosis patients because the FDA is going to mandate that they meet hard endpoints at preventing death, decompensation, and transplant. And in order to equalize the groups, we're going to need scores like this. The second is evaluating ChatGPT-4o's real-time clinical assessments and recommendations in complex hepatology cases using voice prompts. So they wanted to evaluate ChatGPT-4o's performance at providing real-time clinical assessments in complex liver cases compared to that advice of a transplant hepatologist panel. The primary outcome was looking at response times, clinical appropriateness, and actionable recommendations. They did only train on 10 cases, but the performance, they gave recommendations quickly, and the diagnostic accuracy, at least in these 10 cases, was 100%. So certainly interesting, but I think we should all maintain our jobs for now, and we still won't be talking to our phones, but certainly something of interest for the future. Bleeding, beta blockers, and tips. Carvedilol is associated with lower mortality than other non-selective beta blockers in patients with cirrhosis. They compared outcomes of people treated with cirrhosis compared to other non-selective beta blockers like carvedilol, like nadolol and propranolol. This was a multi-center retrospective case control study in a large health system, and they identified people by billing code and platelet count. The primary outcome was all-cause mortality, which was seen here, and then decompensation. They analyzed 2,300 patients, 71% were on carvedilol, and in risk-adjusted analysis, carvedilol lowered the hazard ratio for hepatic decompensation in a very big way, and less so, but still statistically significant in mortality. So using this risk-adjusted analysis, carvedilol lowers hepatic decompensation and mortality compared to nadolol and propranolol, and carvedilol remains my #1 non-selective beta blocker in clinical practice. Spleen stiffness is reliable in assessing hemodynamic response and prediction of rebleeding on beta blocker therapy for secondary prophylaxis after variceal bleeding, the beta response study. They wanted to determine if they could use spleen stiffness by transient elastography or liver stiffness instead of repeat hepatic venous pressure gradient assessment to look at response to carvedilol 6 weeks after a variceal bleed. 220 patients were analyzed. They did liver and spleen stiffness measurements. All patients were initiated on carvedilol. 40% were responders. And the area under the curve for the spleen stiffness measurement did have a high correlation with a AUC of 0.84, which was higher than liver, as well as the spleen stiffness measurement, if it increased substantially, did predict rebleeding. So this certainly didn't convince me to do it, because we tend to up-titrate as much as possible already, and there is considerable variation in the spleen stiffness and liver stiffness measurements over in between measurements. But certainly I think something that needs further validation, but interesting for the future. Comparison of 1 versus 5 days of octreotide, which is what we in the US use for variceal bleeding. I know you all tend to use terlipressin, which is better, but we don't have that indication in the US for variceal bleeding, along with endoscopic therapy in preventing early rebleeding and mortality for esophageal varices, a nationwide, and this was in Thailand, multi-center, non-inferiority randomized controlled trial. They did randomize patients, and it was multi-center, 1 day versus 5 days, and they had a non-inferior outcome of 5%. And they did demonstrate that 1 day was non-inferior when they looked at preventing rebleeding at 5 days and 6 weeks, as well as lowering mortality. It was non-inferior at 6 weeks in these 220 patients. For me, I do use 1 day after control of the variceal hemorrhage in low-risk patients, but in the high-risk patients, I tend to use longer therapy. Low risk would be child A with bleeding or child B with, where you know it's a variceal bleed, but it wasn't actively bleeding at the time. For high-risk patients, we have preemptive TIPS. So preemptive TIPS is associated with better outcomes in patients with variceal bleeding and severe alcohol-associated hepatitis. Remember, preemptive TIPS is the elective placement of a TIPS after you adequately control variceal hemorrhage within 72 hours in those patients with child B cirrhosis, where you see active bleeding during the endoscopy, or child's C cirrhosis 10 to 13 points. They compared outcomes. This was not a randomized controlled trial of 4 European prospective observational cohorts, and the outcome was 6 weeks survival. There were 47 patients in preemptive TIPS group, 95 in endoscopic plus drugs. The 6-week survival was 86% in preemptive TIPS versus 70%, which was significant in endoscopy plus drugs. Rebleeding rate was also lower at 3 versus 19%, and decompensation, death or transplant was also lower by 14 points. And I'm finding myself using more preemptive TIPS, although patients do have to be appropriately selected. Preemptive TIPS, the new standard for gastric variceal bleeding in patients with cirrhosis, results of a large multicenter randomized controlled trial. Unlike the last one, this was a randomized controlled trial to determine the efficacy at rebleeding-free survival in preemptive TIPS in 47 patients and glue versus non-selective beta blocker in 54. This was multi-center randomized trial in 20 centers in France. And you can see that the rebleeding-free survival was better in the preemptive TIPS group. Heart, ascites, and kidney. Point-of-care ultrasound, or POCUS, to assess impact of cirrhotic cardiomyopathy and renal biomarkers in patients with cirrhosis and acute kidney injury. They assessed ultrasound parameters and inferior vena cava dynamics in relation to AKI. This was a prospective study from India where they did serial ultrasound measurements at presentation, 24 hours and 48 hours, and they wanted to see the performance of serial echo parameters to predict acute kidney injury outcomes. Over 350 patients, most were fluid responders, a minority hepatorenal syndrome, a third had cirrhotic cardiomyopathy. And cirrhotic cardiomyopathy was definitely a predictor of the need for renal replacement therapy. So of interest, so I think we're underdiagnosing cirrhotic cardiomyopathy, and those factors in the cardiac index do have a significant impact on outcome, especially among patients with cirrhosis presenting with acute kidney injury. The epidemiology and outcome of ambulatory care community-acquired acute kidney injury, a VA study. The aim was to assess the incidence, risk factors, and mortality with a community-acquired acute kidney injury. It was a retrospective VA cohort, and they utilized the International Club of Ascites criteria for acute kidney injury. They analyzed almost 56,000 people. 13% developed community-acquired acute kidney injury during the 4 years of follow-up. 81% were stage 1A or B. 60% resolved, although remarkably 40% did not. You'll notice that 25% died within 1 year, and that the hazards ratio for death in 1 year after a community-acquired acute kidney injury was double. Certainly something we need to pay more attention to is small fluctuations in creatinine as an outpatient and how to avoid them. Optimal mean arterial pressure targets in management of critically ill patients with decompensated cirrhosis and septic shock. This has been a big debate in the ICU literature, and we've always just adopted the ICU management style not specific to cirrhosis. They examined the mean arterial pressure targets and 28-day survival and AKI non-recovery in decompensated cirrhotic patients. They analyzed consecutively admitted people with cirrhosis and sepsis to 20 ICUs and looked at 28-day mortality and AKI. 1,700 patients in the ICU with septic shock, over 151,000 mean arterial pressure recordings. The ideal target they found was 65 to 75, which is associated with better 28-day survival and AKI recovery, with the ideal cutoff of 75 for both outcomes. And of importance, mean arterial pressure goal, early fluid resuscitation, and early antibiotic administration led to a 67% lower risk for death. I tend to use this 75 during the first 24 hours and then drop it to 65. So certainly the target mean arterial pressure goal under ideal circumstances very early, especially in that first 24 hours, maybe 75 to increase survival and renal benefit in our patients with decompensated cirrhosis and septic shock, but certainly does not replace the other need for immediate antibiotics, because every hour increases mortality and early fluid resuscitation. And hepatic encephalopathy, the efficacy of lactulose alone versus lactulose with polyethylene glycol in the treatment of hepatic encephalopathy, a systematic review and meta-analysis of randomized controlled trials. The aim was to determine the efficacy of lactulose versus lactulose plus polyethylene glycol to treat inpatients with overt hepatic encephalopathy. It was a systematic review and meta-analysis, and the outcome of interest was a hepatic encephalopathy scoring algorithm score. They combined 3 trials, and lactulose plus PEG significantly reduced the HESA scores at 24 hours, but of note, the combination shortened length of stay by almost 3 days. So I really do like trying this, especially in the first 24 hours after admission. Patients with cirrhosis and a history of overt hepatic encephalopathy experienced lower 6-month all-cause mortality rates with rifaximin. The aim was to determine the rate of all-cause mortality in patients with overt hepatic encephalopathy, which is grade 2 or higher, who are treated with either rifaximin monotherapy or lactulose monotherapy. Since no one ever liked lactulose, you can imagine that the compliance is probably higher with rifaximin. This is a pooled post-hoc analysis of 2 trials, with the primary outcome being 6-month mortality. 270 patients were evaluated, and although a small difference, there was a lower 6-month mortality with rifaximin at 1.6% than with lactulose at 4.8%. And it's no surprise that the discontinuation rate in the lactulose group was double that of the rifaximin group. So especially if you can get it from a cost perspective, which tends to be an issue in the US, rifaximin monotherapy may offer a survival benefit, probably because of compliance, versus lactulose monotherapy for patients with cirrhosis and overt hepatic encephalopathy. So in conclusion, there were more than 200 abstracts covered by a myriad of topics in portal hypertension. Preemptive tips improve survival in selected patients with severe alcohol-associated hepatitis and gastric variceal bleeding. Mean arterial pressure goal of 75 in patients early on with sepsis improves survival and renal outcomes. And in patients admitted with overt hepatic encephalopathy, consider adding PEG to lactulose and discharging them on rifaximin. Thank you so much for your attention.
Thank you, Jackie. We will take a question at the end of the session. First of all, I would like to thank organizing committee for inviting this meeting. And I'm very happy the audience is so crowded until now. So now we move to another topic. It's also a very interesting topic. I'm inviting Mr. Bora Peynircioğlu. His topic, tips and other radiologic interventions. Microphone for you.
Thank you, dear chairs. Good afternoon. It's really a pleasure being here. And looking at the experts here and the program, I can, even as an interventional radiologist, I can tell that this is a high-level meeting. So it's really my pleasure being here. So nothing to disclose from my side. We are dealing with the liver a lot for certain aspects of the vascular part of the liver. We are dealing with the hepatic arterial system. We are doing a lot of interventional oncology procedures and hepatic venous side as well for Budd-Chiari liver transplantation, and of course with the portal venous side. So we do a lot of procedures in terms of this liver vascularity. You know the imaging. As a radiologist, we are really interested in the imaging. I probably know that, I can imagine that you are more into the imaging with the ultrasound and the MRI recently, but I would like to draw your attention to the one which is at the bottom. Let me show you. The venography with pressure measurements. This is, I think, the most underestimated procedure that we can do easily in a outpatient procedure, as an outpatient procedure. And I strongly want to remind you that we can do that in a very safe manner with a lot of information at the end of the procedure. So you see the pressure measurements, hepatic venography giving a lot of clue to what we have in this particular patient, and we can do a parenchymal biopsy in this procedure during the procedure itself, and then we can finalize with a nice tissue examples for you. So we have the MRI with the elastography. It's the new kit on the blog, I believe, and you are doing it a lot. We have this procedure. It takes them 1.5 hours in the MRI machines. We are now developing certain protocols that can improve the speed of the procedure, so we can take it less time. So this is the main coming feature for the MRI for, I guess, which you will be interested in. So portal hypertension, what we are going to be talking today, we do a lot of procedures in the portal hypertension, beginning with TIPS. It's been there for almost 40 years now. It's a minimally invasive procedure trying to decompress the portal venous system. And we are basically not, of course, treating the portal hypertension, but treating the complications of the portal hypertension. These are the most proven indications. There's a consensus of treating these problems with the portal hypertension, acute variceal bleeding, which are not being controlled with the medical treatment or endoscopic interventions, and recurrent variceal bleeding and ectopic variceal bleeding are which we deal most. And of course, refractory ascites is there with that variable numbers of success rate reported in the literature. And unproven indications are there as well. We have been dealing with hepatorenal syndrome, hepatopulmonary syndrome, and we have again various success rate for these complications of the portal hypertension. Is there any contraindication? The most prominent contraindication is the heart failure. And if there's a severe hepatic failure, of course, with hepatic encephalopathy, then we are trying to avoid doing TIPS, which we will be, get into more detail in the coming slides. And there are relative contraindications, which are basically related to the technique of the procedure, which we can overcome with experience and nice patient selection. So what is the TIPS technique? It's basically a cannula. It's an angulated cannula at the end. We are trying to get into the hepatic veins and then do a blind puncture. And in our experience, it's just 1 or 2 punctures in the blind puncture from hepatic vein to get into the portal venous side. So as you see here, there's a hole in the tip of the angled needle. This is a Colapinto needle. And you can give contrast. You can send a wire through there, and then you can put a wire into the portal vein. Then you can treat the patient with a stent and balloons. And you can get into the varices. If they are bleeding, you can treat them as well during the procedure, as I will show you this one. This is a patient with HCC, a huge gastroesophageal varices you can see here, and we do the TIPS procedure safely. It's a one-pass procedure in this particular one, and then do the embolization of the varices, both you can embolize the gastric varices, you can embolize the esophageal varices, just to improve the flow into the shunt, and then you can finalize your procedure with a nice result. So we have the Budd-Chiari, and we have many patients in Turkey, so we are dealing with them as well. This is a non-cirrhotic portal hypertension, but still affecting the results of the TIPS, so I just want to show that. So this is what you have in a Budd-Chiari patient. So you don't have the hepatic veins, so you basically puncture from cava to the portal venous side. So this is really technically challenging, and we are trying to overcome it with ultrasound guidance and other, CO2 injections to visualize the portal vein, but sometimes the portal vein is really small in the branches, so it is hard to get into this with a blind puncture because it's a long tract. So what we do is we are trying to tailor our procedure to DIPS, so it's a direct percutaneous intrahepatic portosystemic shunt. So we just basically want to show the case for you. You don't have to use it for only Budd-Chiari patients. You can use it for the hepatic vein, patent hepatic vein patients as well. So what we do, we use the ultrasound guidance to first puncture the portal vein, give the contrast, make sure that we're in the portal vein. So the same needle is going through the portal vein into the hepatic vein or directed to the IVC. So this is the tricky part, which we do very frequently in the interventional radiology practice. And then we just put a wire there and then snare it from the jugular approach. We have a through and through access from the jugular and the direct transhepatic route. And then you can basically do the procedure. And there are some cases with Budd-Chiari. The cava is severely compressed, so we do a balloon inflation there and then aim the balloon instead of aiming the cava because you don't see it in the ultrasound guidance. So we can puncture the balloon and then put the wire up, and the rest is very similar to the DIPS procedure. We can place this shunt very, very easily with this technique in a half an hour or sometimes an hour of procedure. So with the Budd-Chiari, we don't always have to do the TIPS for these patients or DIPS for these patients. We always look for the hepatic veins, and this is again to emphasize the need for hepatic venography and the pressure measurements, because in this patient, you see, once we get into the accessory hepatic veins in this particular patient, there is no flow because of this tight stenosis here, and there's the normal right, middle, and left hepatic vein has already been gone because of the Budd-Chiari. You see the tight stenosis right here, and the flow is not, getting into the cava. So what we did, instead of TIPS, we just do a balloon angioplasty there, and we had a nice result. This is before. The contrast is not flowing to the cava because of this tight stenosis, but after balloon, everything is flowing nicely, and you just avoid TIPS procedure, and instead of just a similar, very simple balloon angioplasty, you save the patient. So TIPS, how to use it, when to use it, it's really, depending on the patient, so we need to be very careful about selecting these cases, but early stage TIPS was recommended in this 2010 publications, but of course, the paradigm is shifting depending on the esophageal varice bleeding versus gastric varice bleeding, or the patient has a refractory ascites. So TIPS failure, there are common risk of TIPS failure, so you have to following these. We are using a covered stents to prevent these bile leaks nowadays, so it's relatively expensive procedure with the covered stents, but still you're saving the patients for a lot of re-interventions afterwards. So we are doing, we can open up the occluded stents, shunts, TIPS shunts, or we can do a double barrel shunts in patients who needs more portal vein decompression. So sometimes we have this hepatic encephalopathy. Many of the patients can get used to it, but still we sometimes need to decrease the size of the shunt. So we have now different stents, different stent grafts, so we can, handcrafted, put a suture around the stent and make it a smaller one so the patient can get used to it. And then after 1 or 2 months, you can just open it up with a simple balloon angioplasty. So we have the old friend, the surgical shunts are still there, but the TIPS is advantageous because it's minimally invasive. There's no need for general anesthesia, no need for blood transfusion, and transplant surgery can be safely done with this TIPS procedure. And the only thing we have to be very careful about, not extend the TIPS beyond the limits of the transplantation. So it's very important to do it in a experienced center, that what I can tell. And also, only option is at the cable occlusions. The TIPS is the only option for decompressing the portal hypertension. So we know that from the recent publications from 2020, the gastric varices is not very much responding to the TIPS because there's a high risk of rebleeding. So we have different studies now coming up, and the gastric varices is now a separate entity from the rest of the variceal bleeding. So how we deal with it with the last 4 or 5 years? So we know that esophageal variceal bleeding is more common, but gastric variceal bleeding is much more dangerous, requiring more blood transfusion, and it's really challenging in, depending on the location of the location of the varices. You cannot reach it by endoscopic approaches. So when to embolize it, how to embolize it. The patient selection is very crucial, but main idea is the same. So what the patients with recurrent variceal bleeding, gastric variceal bleeding, refractory to endoscopic management. So once we have those patients, we are looking for the portal hypertension. If there's any portal vein thrombosis, if there is any other reason for bleeding from the gastric varices, like a Delafoy lesion, or needing TIPS. If the patient really needs TIPS, or you can do that without doing a TIPS, just embolizing the gastric varices. These are the things we are just, it's a kind of checklist for us. So what are the techniques we have instead of TIPS? So we have, if you have a gastric variceal embo, you can just go directly into the TIPS and then do the TIPS, getting to the short gastric veins and embolize the gastric varices. The other one is balloon occluded retrograde transvenous obliteration. It's called the BRTO. It's the a kind of new tool for us, and we are playing it a lot. And the other one is the antegrade balloon occlusion venous embolization, is BATO. And the last one is the partial sphenic artery embolization or splenectomy, depending on the patient again. So what is the difference between the TIPS and the other the techniques, the BRTO and the BATO? So once the TIPS is decompressing, and whereas in the BRTO there's no decompressing, it's just sclerosing the varices. So you're improving the blood flow into the liver. That's the main difference. In the TIPS, you are creating a new hepatofugal shunt. It's more invasive. It has nice result in the esophageal varices because decompressing the portal pressure, but it's decreasing the blood flow into the liver. So there's a high risk of encephalopathy, and for the longer period of time, you can decrease the liver reserve by this method. And whereas in BRTO, you're just closing the gastric varices and the gastrorenal shunt, and there's minimal invasive, you're going transvenous only, no puncturing the liver, nothing. So it's much easier for us also for doing this BRTO technique. And what is different in the BRTO? You are increasing the portal pressure. So if the patient has esophageal varices, it will have more pressure inside. It's going to be huge diameter at the end of this procedure after 2 or 3 months. And also you can increase the transfuder complications of this portal venous high pressure. And of course, transvenous is there, so there's no puncturing the liver in BRTO, but we have to puncture the liver in the BATO procedure to go antegradly into varices. So this is a nice paper from Vael Sayad. He's a nice friend of us working in the US now. And this is a nice description of the gastric varices. How can you, reach into them? If you have a nice inferior adrenal vein, you can just directly get into that and then get into the gastric varices. Or sometimes you have direct shunts from the cava and the gastric varices. You can easily get into them and embolize it. This is a nice, I think, kind of guideline for you to understand how we approach this BRTO or the other procedures other than TIPS. So if you have a splenic vein, thrombosis, you can go directly to the splenic artery embolization, which we will come into that shortly. But if you have everything patent and a cirrhotic patient with global portal hypertension, which is the main topic of this talk, so you have gastric variceal bleeding and hepatic encephalopathy, then it's directly guiding you into the BRTO. And gastric varices, no other complications. BRTO is seemingly superior to the TIPS. With only BRTO, you can preserve the liver function for the future as well. But if you have other transthoracic complications or other things, then you may think about doing the TIPS and gastric variceal embolization. This is a nice chart to think about while selecting a patient and the procedure. So this is a patient with portal vein thrombosis with gastric varices and a huge, massive gastric variceal bleeding. You see the gastric varices bleeding from the cardia side, fundal side. So we just get into the splenic vein, renal vein, and then to the gastrorenal shunt here, and then put a balloon catheter, occlude the extra extra variceal shunts like the phrenic veins and so on, and then we inject the glue, or you can inject the sclerosant, whatever you like, and then you can basically close everything down as you see here. These are the before images. These are the images from before the procedure, and these are after. You see the glue right into the variceal site, and this patient is free of bleeding for the last 15 years. This is one of the early cases with it, and nice, of course, result with the increased pressure, thus leading to increased size of esophageal varices and splenomegaly at the follow-up imaging of this patient. So these are the meta-analysis from the literature. One is from, I think they're both, 2020, and they are saying that the TIPS versus BRTO in gastric variceal bleeding, the results are pretty clear if you look at these papers. And the BRTO is associating with lower rates of rebleeding and post-procedure hepatic encephalopathy, as you would expect, and should be considered first-line modality for treatment of gastric varices because of portal hypertension, if you can. And BRTO is superior to TIPS regarding rebleeding rates and hepatic encephalopathy. So this is the important part of dealing this gastric variceal patient. And of course, we are having other patients with gastric variceal bleeding, as you see here, the Delafoy lesion, and you see the angio. This Delafoy lesion is not very much I would say examined, but because we know that there's sometimes splenic artery occlusion, sometimes bronchiectasis disease causing these Delafoy lesions. There are some cases in the literature, but some patients we don't really show how this developed in these particular patients. And this is before, and you see the band ligation, and then this is after embolization with huge glue artifacts within the Delafoy lesion with no bleeding afterwards. Splenic artery embolization is one of the things we are doing more and more in our practice, not only in the transplant patients, but also in the gastric variceal bleeding mainly. And it's because when you have this portal vein thrombosis with no splenic vein, so splenic vein is also thrombosed, splenic artery embolization is a nice way to decrease the pressure within the gastric collaterals, because they are mainly draining the spleen. So the other thing is, of course, the hypersplenism, as we all know. We are doing a lot of partial splenic artery embolization with less and less post-embolic syndrome due to this glue embolization. Now we used to do it with a particle embolization, which is causing a lot of pain and post-embolic syndrome afterwards, but now with the glue, it's much safer. The complications rate the rates are getting less, and the patients are tolerating much more easily. This is a patient with a previous history of bladder cancer, had a resection, chronic liver disease, and this is a patient presented with a stromal variceal bleeding. And this is the images you see here. There's huge varices is coming here now. And what we do, we can embolize those stomal varices safely, a day-out procedure. We can go from the liver, we can go from directly into the stomal varices. There are, advantages and disadvantages. The stomal varices is mostly dirty because of the area, so you have to be very careful about the sterility and everything. And otherwise, it's very safe procedure doing in both ways. You see, this patient was treated with my junior colleague, and he get into from the left portal vein, getting into the stomal varices, and embolize it with nice. You see the microcatheter down here, getting in directly into the stomal site, and embolize it with a liquid embolication nicely, and get a nice result afterwards. So this is another example we treated all together. I think there are many patients who saw this patient before. This is a patient with a chronic liver disease, refractory ascites, huge umbilical hernia. So the CT reveals some spots in the liver, and then you see in the liver is coming, and there's a ileal hemangiomatosis in this patient. Nice hyper-enhanced areas, contrast-enhanced areas. Some say hemangioma in this patient, some say hypoplastic nodules, and also ileal hemangiomatosis you will see now, it's coming. Let me show you that. It's a kind of blue rubber blebs syndrome, and the terminal ileum, here, you see that. Nice calcifications, huge ileal wall, and this is the hemangiomatosis patient, and then this is the angio, which you will surprise probably. AVM here, draining directly into the portal vein, so it was treated with several embolization of the hepatic arterial AVM and then transplanted. A very, very nice outcome. And this is, we allow these procedures, and the only curative IR approach for the portal hypertension is closing the arterial portal fistulas. That's what we know. Not treating the complications, but the actual portal hypertension, disease. So this is a newborn, 8-day-old, huge arterial portal fistula, decompensated because of the huge aneurysm in the portal vein you see here in the left liver lobe. So we get into the aorta in an 8-day-old kid. It's 1.5 kilogram. You see, once we inject from the aorta, everything is getting into this portal flow, and nothing else is filling. So we try to coil it. It's a very high flow, cannot stop the coils. And then we decided to go for plugs. These are different types of plugs. I'm showing it for the IR purposes only, but just basically we can treat this patient in a half an hour procedure. So a nice occlusion of the hepatic arterial, the arterial portal fistula connection, and then the patient was very lucky to have this procedure at the hospital, and he was gaining the weight afterwards. So to sum it up, TIPS is excellent for refractory ascites and bleeding esophageal varices. We have to concern about the hepatic encephalopathy and, of course, future transplantation. And gastric variceal bleeding is better to be dealt with BRTO first, if possible. This is the data we have so far. And partial splenic artery embolization is safe and effective in patients with hypersplenism and/or splenic vein thrombosis. And patient selection and experience is always the key. So we are there for you, waiting for your patients to help. Thank you for your patience.
Thank you. Now the topic is update acute on chronic liver failure. Please, Dr. Kava.
Thank you, and appreciated that last talk. It's nice to collaborate with our interventional colleagues. So we're going to talk about acute on chronic liver failure, state of the art. No disclosures, so some of the objectives for the next 15 to 20 minutes. So what is acute on chronic liver failure? It's a relatively new diagnosis. We're very fortunate to have Dr. O'Leary here, who's contributed substantially to this. We are going to talk a little bit about some of the prognostication models that we have. What are the precipitants, prevention strategies, and what organ failure should we focus on? And then an emerging area, we've already discussed it today, and I'm sure it was yesterday. Who do you transplant with this disorder? Because it gets quite complicated. So setting the stage for ACLF. So this is just essentially the slide that summarizes the conference, which is the natural course of liver disease. So as you see on the left here, we have all of the different precipitating events that lead to hepatic injury, be they alcohol use, DILI, AASLD, et cetera. And these in selected individuals will lead to pre-cirrhotic liver disease, which will, in the middle of the slide, develop into compensated cirrhotic patients or patients with cirrhosis who are at risk for decompensation. And it is in this setting that we start to see acute on chronic liver failure episodes, which these are organ failures which are related to the liver, right? And we'll talk about the different classifications, as well as extrahepatic organ system failures. And the more significant the acute decompensation, the more we're at risk for incorporating or recruiting other organ systems which fail. And when this happens, these individuals are at increased risk for mortality and require urgent transplant if appropriate. An important concept that we work with the residents on: decompensated cirrhosis does not equate to acute on chronic liver failure. So what's a definition? So I like this from the US guidance by Jazz Bazaz, and this is: acute on chronic liver failure is a potentially reversible condition with chronic liver disease, with or without cirrhosis, but they have chronic liver disease, with the potential for more organ failures, typically within 3 months in the absence of treatment. And this includes treatment of the liver disease, liver support, or transplantation. It's recognized by the presence of some evidence of chronic liver disease, be it elevation of bilirubin, prolongation of the INR. And again, there are extrahepatic organ systems that are involved. The primary extrahepatic organ systems: kidney, lung, circulatory, and brain failure. These are all supportive of the diagnosis. And there are multiple models that we can use to assess the severity of organ failure. So the original model was the EASL-Cliff score, and now we have a NACSELD organ failure score as well. When you have patients with ACLF, they are best managed in the hospital, and many, particularly with extrahepatic organ failures, wind up in the intensive care unit, where the primary responsibility for those taking care of these individuals, in addition to addressing the precipitating factors, is we need to know if these individuals are candidates for liver transplantation. So again, there are at least three societies actually that have major societies that have tried to classify ACLF, and we have APOSTLE, EASL, and NACSELD shown here. And you can see here in the left column here the various organs: liver, kidney, brain, circulatory, and respiratory. The important ways to differentiate these different classifications are that you can look at the major organ failure category. So APOSTLE, ACLF Research Consortium, well, you know, these are predominantly hepatic variables. So with decompensation, you're going to get some ACLF. And this allows actually for a very early diagnosis of ACLF. It's very sensitive, but it's not specific for early mortality. EASL and NACSELD are a bit different. So the EASL criteria you can see here, they incorporate both liver outcomes as well as extrahepatic organ failures as well. You can see kidney, brain, circulatory, respiratory. And again, the issue here is, unlike APOSTLE, the diagnosis of ACLF is made later and sometimes made too late to impact meaningfully disease outcome with interventions. And NACSELD includes extrahepatic organ failures, and again has the same limitation as the EASL criteria. You can sometimes make the diagnosis quite late. And that's shown in this particular graph here. On the left, you can see here that these individuals, I have here the APOSTLE, EASL, and NACSELD criteria, and you can see here that for pre-ACLF, you have the presence of chronic liver disease, but bilirubin not elevated above 5 or INR less than 1.5. You can get to higher levels where you start meeting APOSTLE criteria for ACLF, and then with higher bilirubin levels, INR, you can reach EASL criteria here, and we can calculate a Cliff score. And then finally, the NACSELD categories here, again, are extrahepatic organ failures. And for NACSELD, you need at least 2 extrahepatic organ failures. And these patients are the sickest. They're in the ICU. Reversibility possible, but the mortality rate is high, and they require immediate assessment. So again, just hammering home the point that ACLF leads to extrahepatic organ failures, but the liver is the driver or the perpetrator of remote organ damage. And this happens because of so many of the hemodynamic and other perturbations in those who have chronic liver disease. So when you have the advanced liver disease patient who presents to you, they may have alterations in ammonia metabolism. In the brain, they may have systemic inflammation, changes in cerebral blood flow. Certainly, inflammatory milieu, Kupffer cell, is a source of many inflammatory mediators. You have electrolyte abnormalities, oxygenation abnormalities, hemodynamic instability, nitrous oxide synthesis excess. You have renal artery vasoconstriction, as well as peripheral vasodilation, cirrhotic cardiomyopathy. All of these set the stage to develop multiple organ dysfunction in the setting of ACLF. So with that, how do we manage these individuals? So we address the individual organ failures. So we're just going to talk about the selected organ failures here. So we'll start with brain failure or acute encephalopathy. Now, in patients who present with ACLF, the vast majority are going to have hepatic encephalopathy. And generally, when you have somebody who presents with mental status changes, you want to initiate general care. You want to look for alternative diagnoses, identify and treat precipitating factors, and then also commence therapy empirically or because of documented hepatic encephalopathy. So what does this consist of? This means stabilizing your airway, BP, triage appropriately, antibiotics, intravenous fluids, all if empirically required. For those with mental status changes, drug screen is very important, particularly people come in, in the US, alcohol-associated liver disease is a driver, and so many of our patients who have brain failure encephalopathy, it's related to delirium from alcohol use disorder, alcohol withdrawal, but certainly other neurologic disorders all have to be addressed, and never forget about infection, particularly for us in the setting of increasing alcohol use. I will tell you, in the last few years, we've had more than one atypical meningitis, cryptococcal meningitis, someone who came in with alcohol use disorder, who actually had quote-unquote refractory hepatic encephalopathy, and indeed it was an LP, lumbar puncture, that helped us get to the bottom of what was driving the mental status changes. You have to address infections, bleeding, electrolyte disorders, and again, treating hepatic encephalopathy is lactulose or PO or via enemas, and obviously others, rifaximin. We're big fans of zinc as well. These all can help with the treatment of brain failure in the setting of acute on chronic liver failure. What about in the ICU? Again, here, a variety of different contributing factors. Often these people are quite ill. They may have a delirium from some medicine withdrawal, psychoactive medicines. These individuals also can be quite agitated, and they may have received pain medicine, particularly if you're in your emergency room, and also these individuals may not be able to communicate well. So they need to be sedated. We're big fans of dexmedetomidine, or we call it Dex, which is a very short-acting sedative, which if you turn it off, they wake up quite quickly. The ACLF guidance actually said that they suggested against prophylactic antibiotics to reduce mortality on mechanical ventilation if there's no other particular indication for this, and we'll go over this data well. But you have to identify and address delirium, pain, and agitation, and again, the underlying medical factors here, hyperammonemia, alcohol intoxication, withdrawal, which are in our ICU the driving forces, and of course sepsis and medicines for pain. What about acute kidney injury? So important, not all high creatinines represent AKI HRS, and in fact in most hospital and large series, it's anywhere from 20 to 30% of AKI in the setting of cirrhosis turns out to be AKI HRS. The others are ATN. Now, I'm a big believer that one can have a mixed phenotype. That is, you can have ATN in the setting of HRS physiology, and sometimes these categories aren't neatly siloed. So you do need to evaluate these individuals, and once you've identified your AKI, you need to stage these individuals. Creatinine, you can see here, stage 1, greater than increase in creatinine of 0.3, up to 1.5 to 2, and stage 2 and stage 3 are 2 to 3, and greater than 3 times the baseline creatinine or serum creatinine above 4. The reason the nomenclature were all revised by the International Ascites Club was to allow earlier intervention in those people who have acute kidney injury. And for those who have stage 2 and 3 AKI, you do have to be quite proactive. You intervene with albumin and withdrawal of diuretic therapies if they indeed were on these. And typically for 2 days of albumin, 1 gram per kilogram, perhaps in the discussion, I'm a big believer that if the creatinine has not budged after the first day, that these individuals are unlikely to benefit from another day of albumin. But you also want to make sure they don't have intrinsic renal disease as well. And here's the algorithm for AKI HRS. So you can see here if you have functional renal disease, acute kidney injury, remove your precipitating factors, as is shown on the right. You volume expand these individuals, gram per kilogram. And then if they improve, great. If they don't, then these individuals then are candidates for vasoconstrictors. Happily, after a decade of trying for terlipressin, I think we had 3 trials. We finally got terlipressin approved very recently, so terlipressin is available here, and it's probably been available here for quite some time. We have also in our intensive care unit, and actually on our floor, we have norepinephrine, which requires a midline or a PICC line to insert, but in the ICU, we often use norepinephrine, but these are vasoconstrictors. On the floor, at least in the US, terlipressin was approved with a black box warning for hypoxemia, and if the room air FI saturation is less than 90%, these individuals cannot get terlipressin. They transition over to norepinephrine, or at this point, they may be transitioning on their way to the ICU. What about coagulation failure? This is something that's very important. Our liver teams are actually quite seasoned at this, but when we're consulting on the medicine services, we sometimes have to tell them, take it easy on the fresh frozen plasma. You don't have to go chasing these INRs. This is also true, by the way, in acute liver failure as well. And so the ACG practice guidance for ACLF basically said you don't use the INR as a measure of coagulation risk, and you don't need prophylactic transfusions unless, of course, you have some major procedure that you need to put these individuals through. And in individuals who do require procedures, then you can use thromboelastography or TEG or rotational TEG, which is ROTAM, and these are better versus the INR. This takes into account both platelets, coags, and particularly in those with prolonged INR, and make sure, if you don't have TEG, make sure you're looking at the fibrinogen level and that they don't need cryoprecipitate. That's actually one of our low-hanging fruit consults that we often get, that, hey, we've been giving this person FFP and the INR is still high, and you just say, hey, look at the fibrinogen, give them some cryoprecipitate, and you look just spectacular. So just be careful when you do that, and the TEG will actually guide you there as well. You don't need to just give FFP for the sake of lowering the INR. You do need to look for precipitating factors for ACLF, and infection is a major driver, but there are many drivers in the US with our and elsewhere with the high prevalence of alcohol-associated liver disease. Alcohol-related issues are very, very common, and of course, major surgeries. Of course, major surgeries without having consulted hepatology ahead of time to help decide whether this was a good idea or not. And there are multiple risk modification scores. Vocal Pen score is excellent. Mayo Clinic has a nice score. You can get these online. And of course, drug-induced liver injury in individuals who receive drugs that can lead to idiosyncratic reactions in the setting of chronic liver disease. Another example might be acetaminophen overdose, an accidental overdose in somebody with alcohol use disorder. And again, people with advanced liver disease who maybe get immunosuppressive agents, get viral hepatitis B reactivation. These also are individuals who can present with significant and profound ACLF. Infections are about 30% of the inpatients with ACLF and are associated with high rates of mortality. This is data from the CLEARED Consortium. This is currently, and it's growing, 98 hospitals in 26 regions, but they looked at the admissions for ACLF and found that about a third, 32%, were admitted for infections, and in there was a high drug resistance rate of about 40%. What were the infection characteristics? Well, they were mainly SBP, pneumonia, urinary tract infection, as well as just bacteremias. And when you looked at these individuals, 40% of these were presented with infections that were culture positive, the majority of which are gram-negative bacteria, the majority of which are E. coli, and not surprisingly, Klebsiella pneumonia. There are various regional variations with the presentations, whether or not you're high, middle, or low income. And antibiotic treatment is usually third-generation cephalosporins, but beta-lactams, antifungals, carbapenems, and fluoroquinolones are all used. Again, an important aspect, if you present with ACLF and an infection, your risk of in-hospital death is substantial. So these individuals, you have to identify the infection early and quickly. So how do you know that you have somebody who is presenting with an infection? Well, it's harder in cirrhosis because there are typical signs of infection are impaired due to the impaired immune response. We know that in those who have advanced liver disease, they don't present with a typical SIRS presentation. They may have hepatic encephalopathy, AKI. They may be asymptomatic. And I will tell you, for us, particularly on the medicine services, I think this is the situation where we pick up more SBP. Someone comes in with an AKI, and you just do a diagnostic paracentesis, and you say, lo and behold, there's the reason you have the AKI. This person has SBP. So paracentesis is essential. And again, the white count, helpful if it's high, but it's not always high. Appropriate use of antibiotics will reduce your mortality rates in ACLF. And this was an observation that's actually quite old, but they looked at inappropriate antibiotic administration. This means they didn't get the right antibiotics, they didn't get broad spectrum antibiotics, or they got the antibiotics when they didn't need to. But all of these inappropriate antibiotic classifications led to higher rates of mortality. And you can see here that the odds ratio here was quite impressive across the entire population, but it didn't matter if you had a documented infection, culture positive. Inappropriate antibiotics are an important cause of increased mortality, and it involves drug-resistant organisms. In addition, albumin's great, but too much of albumin isn't great. So judicious use of albumin prevents mortality in acute kidney injury and SBP, but as it turns out, in other infections, not so great. So this was data that was published over a decade ago, but looked at SBP, and you can see in the black here that's circled here, highlighted in red, these are individuals with SBP who are at high risk for renal injury, and they got albumin, and you can see here in the lavender, they had lower rates of acute kidney injury. That is, they were discharged with normal renal function at a higher rate than those who did not get albumin, and the same thing is true for in-hospital mortality. If you did not get albumin, your risk of dying was higher. And what about non-SBP infections? Well, it's the opposite. So this was a trial looking at daily albumin infusion to maintain albumin greater than 3 grams per deciliter in non-SBP infections. And you can see here the albumin group is in the dotted line in the Kaplan-Meier. Here in the second Kaplan-Meier curve, not statistically significant, but actually albumin group had a lower survival. So prophylactic albumin is not appropriate, and then the recent ATTIRE study that was published in the New England Journal also validated this. So regard to infections, check for infection in hospitalized patients. Early antibiotics, if you're not responding, consider fungus. In SBP, albumin with antibiotics, and avoid a PPI. What about getting transplanted? So we've had a discussion about this, and there are arguments for prioritizing selected ACLF patients. MELD isn't great. But there are scores, and Dr. O'Leary actually already mentioned the TAM score, which consists of just 4 variables here. And if you have a score of greater than 2, and these were lactate, mechanical ventilation, age, and leukocyte count, then your risk of having a poor outcome, you can see here in red, is quite significant. So the TAM score greater than 2, ACLF is not a great idea. There's also the Sundaram ACLF SALT score, which predicts 1-year survival as well. And again here, age, diabetes, BMI, circulatory failure, and respiratory failure all can predict this. And when you do transplant in ACLF, particularly a grade 3, just be prepared. The family is prepared. It's a long hospital stay. these individuals stay in the hospital for quite some time. And again, applicable here is that you can also do live donor transplant for ACLF grade 3. Again, it's, it's a severely physiological, stressful situation. Live donor transplant, 73% survival, and high healthcare utilization. It can certainly be done. We can maybe discuss this during the subsequent discussion. Take-home messages. ACLF represents a high burden, and prevention studies, including improving access to healthcare, are important. Infections, look for them. They're important. Treat them appropriately. High index of suspicion for detecting ACLF and infections. Prevent your acute kidney injury. If the kidneys go, your course is going to be much rockier. Remember, always look for AKI HRS. The majority of people with AKI don't have HRS. Albumin is good, but not too much. And there are limits to what we can do. And we can discuss this in the US, we're more proactive about getting palliative care involved. Not everybody is a transplant candidate, and this actually can provide relief to both the patient and the families. And if you don't have transplant as an option, palliative care is an important part of the care of the individual. I'll stop here, and thank you.
Thank you, Dr. Cohen. Now we invite all speakers to the stage for questions and comments. Any questions from audience? What's your preferred fluid for decompensated septic patients? What is your preferred fluid as a replacement therapy, fluid replacement? Which fluid?
Can you hear me? Yeah, there we go. So we'll use lactated ringers is fine. We have some, I think that's what we use now because we had a hurricane and actually we have a big IV fluid shortage here. So actually that's the only one we have right now. But we'll obviously give these individuals colloid as well. But again, only at the beginning, particularly when there's an AKI that's involved.
Thank you.
Yeah, there's some data on that with comparative trials looking at plasmolite versus albumin, 5% albumin, and 5% albumin was a bit better, but certainly what I tend to use instead of that, I never use plasmolite because that was inferior, but I tend to give a small bolus of IV albumin followed by lactated ringers.
Thank you. Any question? Please, Ramazan.
Thank you very much. You mentioned very high number of cirrhotic cardiomyopathy in portal hypertension patients. We are not really looking for cirrhotic cardiomyopathy in our outpatient clinic or also inpatient. Which cirrhotic patient you should be investigated for cirrhotic cardiomyopathy? Can you summarize that?
Lisa von Wagner is one of the faculty at UT Southwestern who's been leading the charge and looking at cardiac outcomes in patients with cirrhosis, and they recently redefined cirrhotic cardiomyopathy, as I know you're aware of. And I think no one's really prospectively looking at it outside of clinical trials, but there's certainly more data now that, especially in refractory ascites, and in patients with HRS, hepatorenal syndrome, that they have a very high prevalence of cirrhotic cardiomyopathy. So I think those are the two groups where we need to look carefully.
Yeah, and there was a fascinating article that was published in the American Journal of Gastroenterology that showed that impaired response to dobutamine echoes remarkably predicted subsequent development of AKI HRS, and they think that this reflects cirrhotic cardiomyopathy, as you said, and we'll eagerly look at other markers.
Thank you for the nice presentations. I want to ask about the prophylaxis of spontan bacterial peritonitis. In the era of the rifaximin, do you still use antibiotics for prophylaxis in your clinical practice?
I think I'll take this one. So we have quite a lot of data on that now. So with the AASLD cohort, we looked specifically at propensity score matched outcomes of people with primary and secondary prophylaxis and showed that patients on primary prophylaxis had inferior outcomes compared to secondary prophylaxis. And then we also showed, in collaboration with Jazz Bajaj, that in patients on primary prophylaxis, there was a very high rate of developing resistant infections. And so he and I have actually discontinued primary prophylaxis throughout the entire VA system nationwide. And I think we just did a evaluation of general hepatologist and GI faculty's opinion of primary prophylaxis because it no longer also portends a mortality benefit, which was shown in 2017 by Moreau and colleagues. So we've stopped completely primary prophylaxis. If you look,
secondary prophylaxis?
Yeah, so we just published an article. It's actually online. It's not in print yet, looking at the risk of recurrence of SBP in patients in the VA system who, this is not a randomized controlled trial, who are on secondary prophylaxis versus those not on secondary prophylaxis. And the risk of recurrence is higher on those on secondary prophylaxis, which was also shown in the TriNet X cohort with a hazards ratio of 1.6. So once again, I think the big problem is what to do. So this is going to, there's an ongoing prospective study looking at this in Europe, and so we're going to wait on those that data. But some of the time I'm using rifaximin.
Okay, thank you.
Thank you very much for your nice presentation. I would like to ask about ACLF. There are some reports, especially from Sarin group, about the usage of GCSF. So the second question is, what do you think about using plasmapheresis as a bridge treatment for liver transplantation in patients with ACLF?
So first question is, what about GCSF? So yeah, I mean, there's lots of potential benefits for GCSF, recruit marrow, stem cells, et cetera. And I personally have never done this. One of the things that I think about ACLF and the way the categories are, there is so much regional variation in ACLF. And so if I'm in Asia or India, I might consider GCSF. I do not routinely use it in our U.S. population whatsoever. Just transitioning over to plasma exchange, there's data on this, that you see some modest improvement, particularly if we're going to transplant with this. But again, I have not, for ACLF, ever performed plasma exchange. I can ask some of the other colleagues here if that's something that they've done.
I'll just answer both. So for GCSF, there was a positive trial that came out of India, but the randomized controlled trial that was multi-center was negative. So that was not in the Indian subcontinent. So we don't use it. And there is an ongoing Apache trial looking at plasma exchange for ACLF. And so it's a very expensive treatment. So we don't use it, but certainly are interested in the data from the randomized trial.
So one more for Bora.
Now, Salih.
Okay.
Yeah, thank you for the excellent presentations. My question also will be about interventional radiology perspective. So in patients with recurrent hepatic encephalopathy, so do you routinely obliterate if there is an existing arteriovenous shunt?
So is the question about the tips or
no, not the tips? It's about AV shunts, like a distal splenorenal shunt, which causes recurrent hepatic encephalopathy. So do you make any obliterations in these kinds of settings?
So the AV shunt, where is it located exactly?
Like a distal splenorenal shunt.
It's not an AV shunt though. It's a venous shunt, right?
I'm sorry. I'm sorry.
Sorry just for the nomenclature. Yeah. So if the patient has hepatic encephalopathy, you want to increase the blood flow into the liver, right? Yeah. So closing the gastrorenal shunts, any venous shunt is going to help the patient in terms of.
What's the experience with you?
So it is. We are just occluding all of them. If the patient is, bleeding from the varices, especially in the gastric varices, we try to close all the, shunts into the, surrounding areas to improve the flow.
But that's not for the bleeding. I'm asking for the hepatic encephalopathy.
Yeah, so there is data on that, actually. And so for patients who have a MELD score that's a regular MELD 1.0, less than 11, then it works great because the liver can handle the increased flow and the subsequent portal hypertension that's created. But for patients whose MELD score is over 11, then they tend to have significant complications as a result of it. So in low MELD patients, yes. In high MELD patients, no.
So maybe same session coiling with the varices and maybe the obliteration of the shunts. I'm just pushing, I know.
The question is very clear, actually, what I would say is if there's no transfer complication with hepatic encephalopathy associated, then you can do the, embolization with everything you like. But otherwise, you have to think about that.
So have you coiled or done so much BRTO that you've wound up having to put a TIPS in the liver to handle the increased blood flow?
Yeah. It is the case.
Yeah, that's the downside. If you shut them off so much, you wind up putting a TIPS in.
Okay, thank you very much. Before we are doing the case presentation, we would like to give a present just for Jackie. Yeah, this is a surprise for you.
Now we have two distinguished speakers for case presentations from Turkey. First, Suna Yapalı. Please, Suna.
Hello, good afternoon. I would like to thank to the organizing committee for the opportunity. My case is a 60-year-old lady who was referred to hepatology in 2024 for minimally elevated alkaline phosphatase and GGT levels. She's a professor at a university in Ankara. In her past medical history, she had breast cancer in 2007 and had bilateral mastectomy, and the pathology was ductal carcinoma in situ. And 10 years later, she had sigmoid colon cancer, and she underwent laparoscopic low anterior resection, and the biopsy was well differentiated mucinous adenocarcinoma and with lymph node positivity, and she received oxaliplatin and capecitabine treatment. Because of the pancytopenic side effects of the treatment, she could just receive 6 courses of treatment. And as she had 2 malignancies 10 years apart, she had hereditary cancer panel, which was negative. In her physical examination, she did not have any stigmata of chronic liver disease except splenomegaly, and her BMI was 21. When we look at the labs starting from 2018, we can see that mildly elevated ALP and GGT levels, and we can see that platelet levels started to be low after she received the chemotherapy. And during her follow-up for the malignancy, she underwent a CT scan, and which we can see that here in the CT scan, she has normal liver size, but spleen, their size is almost 15 centimeters, and she has portal vein thrombosis, which was a partial portal vein thrombosis in the right portal vein. And when we go back to the previous imaging studies done for malignancy follow-up, the spleen size was 13 centimeters in the previous years. And there were also, I forgot to say that, there were also nodular lesions which were compatible with focal nodular hyperplasia, FNH, and those lesions were first identified in 2021. And these lesions were not present in the years 2017 and 18. So she was referred to hepatology, and so the workup for chronic liver disease, underlying chronic liver disease, was done. Her hepatitis serology was negative. Ceruloplasmin and iron studies were normal. Protein electrophoresis and autoimmune serology and IgG levels were normal. Celiac serology was normal. In her past history, she does not have alcohol history and no toxic injury, and she does not consume any herbals. And also, angiotensin converting enzyme and serum amyloid A was found normal. And as she had portal vein thrombosis, she had an extensive thrombophilia panel, and these were all negative. And now she lives in Ankara, and she's being followed in Ankara. And in the center she was being followed, she underwent a fibroscan, and the elastography was normal. She did not have evidence of fibrosis in the elastography. I know that the CAP score is very low, and then the board at the center she was followed decided for the liver biopsy. And the liver biopsy done by the interventional radiology, they did multiple tries, but despite multiple tries, only small pieces of the tissue could be provided, and the biopsy specimen included only 3 portal tracts, and this showed mild portal and lobular inflammation. So what is your diagnosis at this stage for this patient? Any ideas?
Sure, nodular regenerative hyperplasia from oxaliplatin chemotherapy from colorectal cancer.
Actually, this is this patient. This patient presented as non-cirrhotic portal hypertension, and so in 2019, the terminology, the new terminology was proposed, and because the changes occurring in the hepatic microarchitecture, which is located in the lobular branches of the portal vein and the sinusoidal area, was named as portosinusoidal vascular disorder. And for the etiology, as Professor Koh said, oxaliplatin-based chemotherapy is the probable etiology for this patient. So would you consider any diagnostic modality to assess fibrosis in this patient?
The patient did actually have the fibroscan, which showed low, which goes along with the diagnosis of nodular regenerative hyperplasia. The problem with making the diagnosis of nodular regenerative hyperplasia is that you can have smaller nodules or larger nodules, so it's not uncommon, like you said, to have problems making the diagnosis unless you have a wedge biopsy. Right. But you don't need it for this patient. Yeah, go ahead.
Yeah, so I would suggest rebiopsy because according to AASLD criteria, 3 portal tracts are not suitable. So at least you have to have 8 portal tracts and at least 50 millimeters of a sample. I would suggest doing EUS guided biopsy. In patients with EUS guided biopsy, we have almost 10 centimeters of tissue sometimes, yeah.
You know, for NRH, though, to see the architecture, I agree with Dr. O'Leary, wedge biopsy as well. I would actually send this to our interventional colleagues and ask for a 14 or a 16 gauge needle biopsy if I could get them to do it.
Do you do that?
Right, you need like a good blood pressure and a pulse with the biopsy. I mean, a nice, good piece of tissue.
But with the EUS guidance, I can go from the top to the bottom all the way.
19 gauge.
But it's 19 gauge.
19 gauge, of course.
Right,
It has to be 19
that's slim. That's the only, that.
Versus 16, yes.
Yeah, 14 to 16, yeah. And because you need to see the architecture.
Yeah, the big problem, this is specific to nodular regenerative hyperplasia, that you just have to have a lot of tissue or you totally miss it.
She had fibroscan. Does she need any further assessment for fibrosis with the score of 5.3?
No, so I don't think so. Like, to me, this is done. Like, this patient has nodular regenerative hyperplasia, even though you can't get access to it, and the risk-benefit ratio is not there.
So
but if you wanted it,
she does not need any further investigation.
The only thing I think in this patient is that there's MRI is missing, right? Because we have this nodular hyperplasia diagnosis from the CT. And in terms of those patients, we prefer to have MRI with, liver-specific contrast agents to have the liver reserve and everything, functional reserve, to see better.
Yeah, she actually had MRIs. MRIs done. I didn't mention because I didn't want to extend the duration. And the MRIs done. She also had the MRIs done with Primovists.
I'll just make a comment about nodular regenerative hyperplasia. There's actually a working group for the Banff Allograft Histology International Working Group that's led by Funda Yilmaz from Turkey with Mylene Seba, and they have created new biopsy criteria and stratification for nodular regenerative hyperplasia, and they're trying to extend it into allograft pathology. So that's sort of the next step.
Please go answer.
So another opinion is instead of any invasive procedures, if available, MR elastography can be considered. But this patient seems to be clear. And in September 2024, the abdominal MRI showed partial thrombosis in the main portal vein and the right portal vein, which were partially recanalized. The nodular lesions were stable, and the spleen size is around 15 millimeters, and there was no ascites. And this patient is all the interventions are being done at different centers. She's not being followed by the same physician. And EGD was recommended, but she planned to, this was in Istanbul in our center, she planned to undergo EGD in her city, and low molecular weight heparin was started at an outside hospital. And in December 2024, she presented to the emergency room in Ankara with hematemesis and melena, and the EGD showed grade 3 esophageal varices with stigmata of recent bleeding and underwent band ligation. There were no gastric varices, and there was portal hypertensive gastropathy. The EGD done in the last 3 years showed no varices. Low molecular weight heparin was stopped, and she was discharged after the control of endoscopic band ligation. She was discharged on carvedilol and PPI treatment. So at this stage, what is the etiology for the variceal bleeding? She had a portal vein thrombosis. Do you think an increase in the portal vein thrombosis, or is it a decrease in the hepatic reserve?
Well, so in this case, it's the portal sinovascular disorder leading to increased portal pressures. You didn't actually measure the pressures, but I'm sure they're elevated. Sure, the portal vein thrombosis the extrahepatic portal vein thrombosis may have contributed to some small degree, but, I actually, think that it's maybe more the portal sinovascular disorder. The very original CT you showed, you could also see varices along the stomach. So it wasn't like they were already there ahead of time. So as the portal vein thrombosis has come, it's probably tipped her over, but it's those two things combined.
Actually, the MRI right after the bleeding showed that the portal vein and intrahepatic portal branches and supramesenteric vein and splenic vein was patent. Inferior vena cava and hepatic veins were patent. The liver contour was lobular and left lobe was smaller with normal caudate lobe. The nodular lesions were stable and the spleen size was a little bit larger. And 4 weeks after the band ligation, she had a control EGD at another center showing grade 2 varices, and band ligation was performed. So as a summary, the clinical presentation of this patient first started with liver nodules, mainly FNH. FNH actually shows us the hyperplastic reactive lesions resulting from the imbalance between the portal and arterial areas. She first developed portal vein thrombosis, and until variceal bleeding, she was asymptomatic with only mild elevated alkaline phosphatase and GGT levels. Liver synthetic functions maintained with normal bilirubin and albumin levels around 4 gram per deciliter. And unfortunately, the liver biopsy was suboptimal, but this is also a characteristic for those patients. We did not have any concrete evidence of cirrhosis. And in the past, the idiopathic portal hypertension term was on the top of the iceberg, but it's with the previous terminology, non-sterotic portal fibrosis, hepatoportal sclerosis, incomplete septal cirrhosis, and nodular regenerative hyperplasia are the conditions underlying this and the downside of the iceberg. And so portosinusoidal vascular disorder is proposed in 2019 by the vascular liver disease interest group, and it includes the presence of portal hypertension. It may also the concomitant diseases, chronic liver diseases and concomitant liver diseases in the absence of cirrhosis, and portal vein thrombosis may accompany these cases. In the etiology, immunological disorders, infections, HIV treatments, drugs such as azathioprine and oxaliplatin, as we had seen in this patient, toxins, genetic predisposition, and thrombophilia are the etiologic factors. These patients, for 20% of these patients, the variceal bleeding is the initial presentation. Ascites and encephalopathy are uncommon, and portal hypertension develops in 20% of patients with an average of 10 years of diagnosis. Here we can see the Waldick criteria, the study interest group, the splenomegaly, the signs of portal hypertension is required. We have to exclude the chronic liver diseases, exclude the chronic liver disease, and also we have to exclude the non-cirrhotic portal hypertension etiology like congenital liver fibrosis, sarcoidosis, schistosomiasis. And although it's required patent portal and hepatic veins, we know that portal vein thrombosis is accompanied in those patients. The study group identified the criteria. Here in our patients, the specific criteria are for the signs of portal hypertension, the varices, portal hypertensive bleeding, and portal systemic collaterals. These are present in our patient. And also the non-specific criteria were low platelet levels and splenomegaly are the criteria. And also sometimes for the diagnosis of these patients, Budd-Chiari syndrome and also sinusoidal obstruction syndrome, which these are the outflow obstruction problems. These should be excluded for the diagnosis. Here is these are we see a normal portal tract with portal vein and interlobular bile ducts, and portal arteries. And here we can see that the portal vein is the disappearance of the portal vein and obliterative portal venopathy. And also here we can see that the portal vein, obliterative portal venopathy. And in the last three images, the nodular regenerative hyperplasia, the nodular lesions adjacent to the atrophic hepatocytes. And just for the mechanism, in toxins or with oxaliplatin treatments, the oxaliplatin increases the permeability of the hepatic sinusoidal endothelium. So it increases the free radicals and the metalloproteinases. And so the angiogenic factors are, because of this, the angiogenic factors migrate to the distal space, and it increases perisinusoidal fibrosis. It leads to perisinusoidal fibrosis. So all these cause a hypoxic environment here, and this hypoxic environment is the reason for the nodular regenerative hyperplasia. And also this obliterates the capillaries and leads to portal hypertension. My last two slides, the persistence of thrombocytopenia should raise the suspicion of the sinusoidal damage. So this is for the this is a recent study. This is my recent study, which shows the natural history and long-term outcome of patients with portal sinusoidal vascular disorder. It has a long, it's a European study including a large number of patients. 1/3 of those patients were symptomatic at diagnosis, and most presented with variceal bleeding. Transplant-free survival at 1 year was really good, and at 5 years it was 83%. Only 3 patients developed HCC after a median follow-up of 52 months. And for the liver transplant survival, the creatinine, bilirubin, albumin, associated conditions, and ascites at the diagnosis are important prognostic factors. And this is the summary. A better understanding of the clinical manifestations may increase the awareness of the physicians and the early diagnosis, provide the early diagnosis. Thank you very much.
Thank you very much, Suna. Now we are moving to another case presentation. Dr. Nilay, she comes from Izmir. Just be care of time, please.
Yeah, sure. My slides, please. First of all, I would like to thank you, organizing committee, for giving me this opportunity to speak here. It's a great honor. Thank you. My patient is 48-year-old man, presented with dyspnea and weakness, started almost 1 year ago. When we look at his past medical history, he had some chronic diseases, autoimmune hepatitis and primary biliary cholangitis, which was diagnosed in 2016, and hypertension, diabetes, and chronic obstructive pulmonary disease. There was no SBP or HAS or variceal hemorrhage before. And his medications are aldactone, furosemide, nebivolol, empagliflozin, inhaler steroid and beta agonist, azathioprine, and UTCA. He had an operation of 30 years ago because of splenomegaly, and it was splenectomy. No active alcohol or smoking, however, he was an ex-smoker. In his physical examination, he was hypotensive, no hepatic encephalopathy, no normal sclera. However, he had pretibial edema. However, there was no jugular venous distension. And this was the lab when he admitted with dyspnea. You can see slightly elevated AST levels and ALP levels, and total bili was 4.5, and low albumin, and there is no electrolyte imbalance, sorry, and platelet levels are normal. However, INR was elevated. These are the lab levels And the patient was, there's a distinct shot you can see here. And the patient, because stopped coming routine control during the COVID period. The first green part of the INR levels belong to the before COVID time, and after COVID time, the liver got worse. So AST levels, ALT levels have some fluctuations after he came again. So better GGT maybe, ALP levels never are in the satisfactory levels, and directly started to increase. And in his abdominal MR, there are the signs of liver cirrhosis and patent umbilical vein, thrombus in main portal vein, and collateral vascular structures at the mesenteric level, perigastric area. However, in his EGD, there is no varices, just minimal congestive gastropathy findings. Because of dyspnea, thorax CT was performed, and the pulmonary tract diameter is above normal, and effusion in pericardium was existed, and there was increased ventilation in both lungs. So, what are the possible diagnoses? To sum up the patient, I just give the points. 48-year-old male, diagnosis of cirrhosis, portal hypertension findings, however, no ascites, no varices, pretibial edema. Dyspnea started 1 year ago, and there was a pericardial effusion. May I go on, or?
Does he have constricted pericarditis, or
does
he have constricted pericarditis?
Pericarditis, okay, thank you.
So I was going to can I just embellish what Dr. O'Leary said? Constricted pericarditis, maybe with pulmonary hypertension as well, given the edema. And then it still could be, I guess, hepatopulmonary syndrome as well. It's in the differential, though he's not really cyanotic. So,
yeah.
But I would at least be considering it.
Thank you so much. And I'm going on. And these are the electrocardiograms of the patient. And you can see the huge difference. And in his initial electrocardiogram, there are some signs of atrial right heart problems. However, in 2024, you can see a right atrial enlargement and incomplete right branch block. They are the findings of right heart strain. So he had an echocardiography. And I should take your attention to some these numbers. I mean, pulmonary arterial pressure is 60, and over 20, as you know, is a pulmonary hypertension. And he had tricuspid regurgitation level 2. He had level D shape and pericardial effusion. Topsy means he had depression in right heart function. So this was the initial echocardiography when he was prepared for liver transplantation, and POP is borderline, as you see here. There was no D shape, and there was no pericardial effusion, and tricuspid regurgitation was grade 1. So his functional capacity was class 2. Class 2 means mild symptoms and slight limitation during ordinary activity. So 6 minutes walking distance is 320, slightly decreased. However, during this 6 minutes walking distance test, there is no desaturation. And blood gas shows us no hypoxemia and no desaturation. So this is important to exclude patient to hepatopulmonary syndrome. And his pulmonary function test shows us restrictive, slightly restrictive pattern. Ventilation perfusion scan was performed, and it was normal. It also excludes. It also helps us to exclude hepatopulmonary syndrome. One of the reasons of pulmonary hypertension is chronic pulmonary embolism. So this lower extremity venous Doppler ultrasound is normal. So we also we can also exclude chronic thromboembolism. So his echo contrast was normal, and these also exclude hepatopulmonary syndrome. So what is next?
You need a right heart cath.
Yeah, sure. And right heart catheterization was performed, and it showed us pulmonary artery pressure is 47, sorry, and pulmonary capillary wedge pressure is 13. I just want to remind these two numbers, not more. And his pulmonary PER is 4.6, and portal hepatic pressure gradient is 7. This means he had a portopulmonary hypertension. And pulmonary angiography showed no findings consistent with chronic thromboembolic pulmonary hypertension. So when we go on with the chart, we should perform transthoracic echocardiography patients with chronic liver disease or portal hypertension with deep dyspnea, and all patients who are candidates to liver transplant. In that area, we can separate the patients, and we can go on. I just want to draw your attention to the right place. And a TRV is over 2.9, and this means there is medium or high probability of portopulmonary hypertension. If right heart catheterization show us a mean pop over than 20, this means this patient has portal pulmonary hypertension. To exclude the other reasons, and we can go on for this patient, and mean pop is more than 20. Pulmonary arterial wedge pressure is less than 15, and PRV is more than 2, means this patient have a portopulmonary hypertension, because volume overload is also excluded with these numbers. And the patient is with this mean pop is in this patient, liver transplantation is contraindicated. So we should start something. To diagnose portopulmonary hypertension, there are some diagnosis criteria. The evidence for portal hypertension plus pulmonary hypertension criteria are used for that. And we know that one of the complications are portal hypertension, and portopulmonary hypertension is, according to the WHO group, it's group 1 and precapillary pulmonary hypertension. Just to exclude the other diagnosis, I just want to get your attention to the right place. And we know that portopulmonary hypertension is less common than hepatopulmonary syndrome, and the pathophysiologic mechanism is excessive endothelin, and mean pop is more than 20, and with the liver transplantation, patients could get improvement with the drugs of portopulmonary hypertension. So in terms of portopulmonary hypertension, we should remind that TIPS shouldn't be performed in portopulmonary hypertension. Non-selective beta blockers shouldn't be used, and no calcium channel blockers shouldn't be used. Current therapeutic targets are for endothelin and for prostaglandins. So our patient also started to use mestantan and ilioprost. I can get. What about the prognosis of the patient? With the eyes of Ramazan Idilman, I should stop, I think, because he is looking at me. So with the diagnosis of portopulmonary hypertension, mestantan ilioprost treatment was started. He came with cardiac decompensation to the emergency room. After hospitalization in ICU, he passed away before comprehensive workup could be done. And thank you for your attention.
Okay, thank you very much for speaker. Unfortunately, we have no time. Now just 15 minutes for coffee. Okay, so another session will be start 4 p.m. Okay, thank you very much. Maybe we can take a picture together.